I'm John Loonsk, and with me is Arun Srinivasan, and we're going to be talking about two activities that we've been pursuing for a little while in FHIR. We're going to start by giving you some general context, me for surveillance and reporting, and Arun for eReferrals, and both in a public health context. So then, after that, we're going to dive into some of the complexities of what we've been trying to work through in multiple connectathons around facilitating these activities for public health. So that's our agenda, and we should have plenty of time for Q&A at the end. So first, for those of you who don't know, surveillance is really the cornerstone of public health practice. Every state and territory in this country has laws that require reporting for 100 or so or more conditions. And the compliance with that reporting varies by condition somewhere between 6 and 80%. Widely variable compliance. This has been a problem. It's not an easy endeavor. The reporting is done mandated by state laws. The state laws differ. And with that many different conditions, you can see you have a multitude of possibilities for what data need to be reported. And the specific data need to be reported. Because the state laws mandate what is required to be reported to the states are very specific about assuming that they can only get those data and not other data. So they can only get the data necessary when a condition is reportable. That's the basic essence of the nationally notifiable disease surveillance system, where diseases and data end up at the CDC. But the first step on that, which is what I'm focused on right now, is just getting the data out of clinical care and to the state or local public health agency, which is what we talk about when we talk about case reporting per se. So it's a many by many problem. Public health has endeavored to try to make this easy and accomplish this surveillance in a variety of different ways, including using ADT messages, so admission, discharge, and transfer messages, in the context of syndromic surveillance, for example, to try to do surveillance that can be helpful, but not burden healthcare. Another effort has been around using direct reporting of lab results. You may know this as ELR, electronic laboratory reporting, where instead of trying to go through healthcare, one can go through the large labs. One can also go through healthcare organizations for smaller labs, but to get the lab results to try to address this reporting and surveillance issue. And of course, when you have the lab result, you have the lab result. And that's not all conditions that are reportable by lab. And as many of you I'm sure know, there's not a whole lot of clinical data in a lab result that can be used for surveillance purposes. But it has been helpful. So public health has struggled historically trying to get clinical care and EHR vendors to implement even what is required by state law. Now think about that. The state laws require this reporting of providers. In large respect, that expectation has been a manual process using forms and fax historically. But now that, in fact, electronic data and EHRs are a requirement, essentially, of every clinical care setting, we should have an expectation that this reporting is done electronically as well. And there is a major initiative nationwide to do just that, to work on electronic case reporting and to support it as an activity of getting data from electronic health records and providing them to public health agencies at the state and local level. And that's what I'm going to talk about after Arun gives you a few thoughts.
Sure. Thanks, John. So good morning, everyone. So I'm going to just give a quick background to the chronic disease space and some of the work that we are doing in the eReferrals. So chronic diseases presents a significant burden to United States with an overall budget of over 3.3 trillion healthcare cost alone attributed to chronic diseases, and over 6 to 6 out of every 10 adults in the U.S. have a chronic condition, and 4 out of 10 actually have more than 2 conditions. So, so chronic diseases is a major challenge, and one of our core missions of CDC and public health is trying to prevent the advancing of chronic conditions. So, one of the major areas that we all work on is the clinical community linkages, where we're trying to connect individuals and healthcare providers and the community programs. Talking about referrals, we're all familiar with typical referrals that we receive from when a provider refers to another specialty care provider or a specialty person, and they are all within the realm of the HIPAA compliance within the healthcare entities or between healthcare entities that are covered within HIPAA. But the prevention programs, particularly the weight loss programs or quit line programs or diabetes prevention programs, these are initiatives that happen outside the healthcare entity, like, for example, a YMCA or a local gym or a mom and pop shop across the street providing a specific service towards one of these conditions. So facilitating referrals from a clinical side to a non-clinical or an extra-clinical program like that requires specific levels of segmentation of data, because they are not within the authorities of receiving the entire clinical data set. So, and also the recipient, in case the programs are also not comfortable about receiving data sets that they shouldn't be looking into. So this is a major challenge, and the lack of existing workflows within EHRs to support such an external referral program has been a challenge in initiating this. Typically, we have studies that show that whenever a physician generates these referrals, there is more adherence from the patient to actually go through the program than a non-physician initiated referral. So, so how can we make this implementation that can happen within that? What are the essential standards there? So that's where our efforts went into to start with looking into the space. But the other challenge is also when we start thinking about referrals, it's not unidirectional. It's about how can both the provider and the program both benefit from in terms of the data sets. So how can this be facilitated in a bidirectional fashion? So that's kind of where the work started with. And there's a significant level of integration or harmonization that happens with the reporting space and in terms of the referral space from the foundational architecture of how FHIR is being implemented. And that's the mechanics that we'll be talking in the next few minutes. So, John, I'll hand it over back to you, and we'll go from there.
Thank you, Arun. So what you've heard already is that multi-organizational data exchange is an important part of public health activities, and that data authorities and getting the right data in the right place is an important part of supporting that multi-organizational exchange and activities around surveillance or these extra-clinical referrals, for example. So believe it or not, at the same time that the compliance of surveillance and reporting is what I said it was, 6 to 80% depending on condition, there is still considerable pushback on public health as a burden to healthcare. And ONC released a provider burden strategy recently for comment. And in it, public health had a special spot in the sun as relative to public health reporting and the burden that it is perceived to place on providers relative to supporting that activity. And of course, burden is a question of perception. And to some extent, that perception emanates from the fact that clinical care has not historically gotten a lot of information back from public health. And so the act of reporting, the act of surveillance is not in aggregate seen to be to benefit clinical care to some extent. But all of this sets the stage for what we're trying to do with FHIR, and we think FHIR offers a series of opportunities to do this differently going forward. So what are those specific requirements? Well, we're going to try to reduce provider burden and do that by automating reporting. Now, we're doing this right now in CDA, but FHIR can help facilitate that even better. So instead of a provider having to manually report, to find the right agency to report to find the right form to fill out, to do all that work of entering that data, which then is not infrequently responded to by a public health investigation to get more data in support of that. We think we can provide a much richer data set in an automated fashion where the provider doesn't even have to initiate the report. It can be done for them. We also want to reduce burden by minimizing the time and effort necessary for interface development. And this is a critical factor. We, in public health, despite having the law on our side, still have to beg, borrow, and steal to try to get EHR vendors to implement the data reporting that we're talking about. And we view FHIR as providing a great opportunity to minimize interface development. That we would love to say automate it, that that FHIR implementation guides they're electronic, they're consumable. They can be consumed by a FHIR server, which conveys a lot of the information necessary to provide those data. And that, we think, is the starting point for greatly reducing the time and effort necessary to develop specific interfaces, and that will, in fact, benefit public health. We're also working to harmonize with other reporting initiatives that are ongoing, and I'll come back to that a little later. We've been working with the Da Vinci initiative to try to harmonize around reporting that is done in the context of value-based care, and in the context of some of the implementation guides that they've been developing. Not all of them, but some of them are about quality measure reporting and other kinds of reporting, and we're trying to work with them. And on the referral side, we've been working with the 360X initiative to try to harmonize around clinical referrals that they've been advancing, because the more of us that use the same approach based on the same standard, based on the same stack, the better off we'll all be in terms of getting implementation. But what I'm going to talk about specifically is implementing an architecture where as much of it is consumable and computable as possible. And I think if those of us who have been around long enough, you think of HL7, you think of standards, you think of 2.x, you think of CDA, and you're really thinking about the data and a standard that specifies what data are to be conveyed. And that is certainly part of the picture we're talking about. But now we're talking about so much more. And then what I am going to talk about, and I think we set the context for this a little bit in terms of thinking about use cases where the data authorities are prominent in defining the use case, is we're really talking about use cases that where push data exchange has been a very useful model for how data move from one organization to another. And we know, we've worked with, we love RESTful query, we love apps, we love the possibilities for what FHIR can do in that respect, but there's an important side of this where these use cases particularly lend themselves to asynchronous data exchange, to asynchronous push data exchange, and we're going to talk about some of the technologies for that in terms of making that happen in FHIR as well. So diagrammatically, this is a little bit of what we're doing, and this is implemented right now. So there are a series of the major EHR vendors have committed to this implementation. We're doing this in CDA right now, and what it looks like is that we distribute information to clinical care that the EHR vendor health site uses. Right now, that's specifically around triggering in the workflow, triggering the initiation of a case report. So I mentioned we don't want the provider to have to initiate that. It's fine if they do. That's a good use case as well, but we want to automate it. So we have worked on trigger codes, value sets that are provided, distributed to the EHRs, and then when one of those is matched, maybe in a diagnosis or a problem list, it could be in a lab result, it could be in a medication order or administration. When that trigger code is matched, it creates what we call the electronic initial case report, and that is then pushed out because there's a lot of logic that beyond just matching it. So triggering is an important step. It's saying that something happened and we suspect that there may be a reportable condition. But then there's additional logic that needs to be applied that says that it is indeed reportable, confirms its reportability, and then to whom it is reportable. So even the statistics I gave you earlier about compliance didn't really factor in the fact that most people don't know that when you are seen in a particular jurisdiction and you're from out of state, frequently that, and you have a reportable condition, that is reportable to the state of your residence, not just the state of your care. And so there are actually two public health agencies, two jurisdictions that need to be notified frequently of the fact that something is reportable. There's logic to that. There's logic to the construct, the additional detailing about what is reportable and what's not. That's what's ensconced in state laws. And so what we have is a platform. What we're using is a platform that applies that logic right now. That's a common platform outside of clinical care. It's, and those are remote rules. But we're also looking, as we move forward with FHIR, to be able to move those rules into clinical care and in the richer FHIR environment, be able to apply those rules as well as the triggering activities there. So there's more to this architecture, but as you can see, push messaging is a part of this. I talked about the logic, I talked about triggering, and I'd now like to talk about the directions in FHIR that can help us get there. But are there questions on just the general layout of what we're describing here? Okay, so consumable, computable, standards and specifications, not just for the what of what's reportable. That's what we've concentrated on with standards so much to this point. But also so that we deburden clinical care, we want to be able to convey the when, where, and how of reporting and be able to convey that in such a way that is processable in the FHIR environment inside of clinical care. So what are the standard artifacts that we have been talking about using in this regard and have begun to implement? So first, there's this act of distributing this guidance out to clinical care sites. And what we've built is a FHIR subscription service that will be held on the Common Services platform, whereby the clinical sites, EHR vendors, and healthcare organizations will subscribe to that distribution using FHIR subscription, among other ways, and then be able to get both periodic and emergent updates to the value sets for the trigger codes and potentially the rules for other information to be distributed. Important concept. We need to be able to communicate to clinical care in a relatively short time period that there are new codes that need to be surveilled for because of an emergent condition. And part of what we're trying to do here is automate that distribution, and we're using, for that purpose, FHIR subscription, even though the EHR vendor doesn't have to have implemented FHIR right now. It's an XML file. It could be any other XML file. It's a JSON file. It could be any other JSON file right now. But that's what we're using. We're using FHIR subscription. And what we're sending out there is structured through a FHIR plan definition. So this construct, Bryn Rhodes is in the audience. This is his baby to a large extent, and others obviously as well. But this is coming more from the guideline space of describing what needs to be done in a clinical setting to carry forth with an activity. We're using this to talk about what needs to be done in a clinical setting about reporting and to be able to convey the different artifacts that help constitute all of that. So we're talking about a broad framing of using plan definition and, for example, conveying the trigger code value sets in that. So inside of the plan definition specification is a series of trigger codes. There are 5 different categories. I'll mention those later. They are conveyed through plan definition. Eventually, in plan definition, you can stub in a CQL library. We intend to build that space out for a variety of different uses when a CQL can be readily processed in EHRs as well. That we don't know what that time frame will be, but there's an opportunity to do that. There's also metadata in the plan definition about the reporting process, the timing of it. So if you think about it, and there's an encounter in a hospital setting, for example, you don't want to report necessarily when the patient just arrives at the door, because not a lot of the clinical data have been accumulated yet. So you want to delay there. Then if it's a really long stay, you want to send periodic updates through the stay. And then there's the issue of how do you send a cleanup at the end of this encounter and what the timing of that is. And there are complexities there too. Encounters are not well defined, let's just say, in the standards world. So, but that kind of metadata about timing is something that we can convey this way too. So we're trying to be able to convey that kind of information in computable form in addition to just the what. This is the how or the when of reporting as well. And then we use FHIR Messaging, certainly as, and FHIR Messaging is just basically a FHIR bundle. A FHIR messaging bundle and a FHIR message header. It's a very small thing, but what it does is it says in it who the penultimate recipient of that is intended to be and who the sender is, and just a few other data elements. But those are critical data elements if you're trying to pass those data through an intermediary on the way to, for example, a public health agency. In some states, they required to use a health information exchange to get the data. Some states may use direct. Some HIEs have other technologies that they use. There's a variety of different intermediaries that play a role in reporting. We need to be able to support that before FHIR, and we need to be able to support some of that going forward with FHIR. FHIR messaging is helpful in that regard as well. We specify a complete RESTful transaction, but we're also specifying a messaging transaction where the bundle can be conveyed using legacy transport as well. So a FHIR message bundle on top of direct, for example, is a completely viable implementation, particularly in the short term. And then, yes, the data specification itself, the what of it, and as I mentioned earlier, the FHIR structure definitions are computable. That's a big part of this picture for trying to be able to convey this all in computable form, to try to automate the interface development. And that doesn't mean that everyone puts all of that information into that structure definition. And as you're developing a implementation guide, it is important to pay attention to the fact that what's going in narrative is not going to be automated in its implementation. And there are frequently decisions to be made in that regard as well. So this is what the plan definition grossly looks like. As I said, we're sharing this. We have this service that is to share this with EHRs now, even when FHIR is not completely implemented in all settings, because it's an XML file and that can be pointed to and downloaded by anyone. And it's also in JSON format. The trigger codes that are an important part of this, particularly right now, they are a large part of what's in this distribution, fall into the value sets that are defined here. So there's one for diagnosis and problems. There's another one for organism substances, lab order tests, lab observation test name, medication order and administration. And you can think about those value sets when you think about the fact that different lab results, for example, in clinical care, the reportability is sometimes it's conveyed in the test name, sometimes it's conveyed in the result. And that is a challenge in this regard, but it's part of the complexities we're working with, and triggering these then passes those EICRs on to those initial case reports on to a more robust rules engine that applies a more complicated logic to confirm the reportability. There are important authorizations and business. This could be a talk about law and about a legal architecture for how this is done. But the way that that's implemented right now is that the common platform is a business associate of the covered entity that is the clinical care organization to be able to convey these data to them. And then the platform makes a public health disclosure to the public health agency, which is a state agency and not under HIPAA. So we could talk about the complexities of that whole legal arrangement, but in essence, this is a techno-legal architecture. And part of what we're doing here is lining up the technologies so that they can fulfill the legal expectations as well as the business need that is surveillance. So there have been some headwinds in talking about FHIR messaging in the FHIR community. I think for me, FHIR is enabling of all these things in the broad agenda that I've described in a very helpful way. Messaging is can be supported by a post or a put, a RESTful submit, but it's sometimes not perceived to be a pure RESTful transaction. But when you're thinking about using intermediaries and passing data through them, it is one that is very helpful to that. And this is the way we've lined that up. So we certainly have legacy transport we'll be dealing with for some time in the industry. But that concept of conveyance of a message bundle that at the top level of an electronic initial case report is encapsulated in a bundle that is of type message in a purely a RESTful post or put. Not all of the data necessarily have to be conveyed in that post or put. Sometimes they're pointed to back on the FHIR server from which they are emanating. And if these data are bundled, that's one of the benefits of bundling at the top level is all the data are conveyable inside that bundle. And in a FHIR document, there's an expectation that all the data are conveyed because of what a document represents. But in a composition or in other FHIR resource constructs, it's not always the case. That's one reason for it. The FHIR messaging always has that top-level messaging bundle. And then that points to, as a focus, the FHIR message header, I'm sorry. And that's a typo there, but the FHIR message header is underneath the bundle. And then the FHIR message header points to the FHIR, to what we're implementing, which is a FHIR task resource, which is describing aspects of the workflow for that report or that referral as processed. And then the FHIR task resource points to the remainder of the FHIR data payload. So I apologize for that. The header snuck out of this as I was creating it. It's one more row of complexity here, but it lays out pretty simply. We are working on specifying the task resource values and aligning them with the different activities that are ongoing in the referral construct. One of the things that the 360X group has been working on are relatively complex workflows around a referral that's made to a potential program that's refused because it's not available to be supported, and then the referral be made out to another program. Those are the kinds of workflow activities that need to be articulated in this kind of setting. And also, the FHIR message header has some information about simply, as I talked about before, the conveyance of data from through an intermediary or from point to point. And we're working to align those to make those consistent in terms of implementation. So FHIR messaging is still not normative in R4, and there are still some things that need to be worked on. One of them is, for example, that when a message is received, a FHIR message is received by a FHIR server, it stops. That's what's done with it. It's received. And unlike a transaction on a FHIR server where a series of follow-up steps are implemented, a FHIR message is not implemented at that level yet. Rishi in the back here has developed code that takes a FHIR message that can then unbundle it, convert it into a transaction, and then resubmit it as a transaction. It's a relatively simple activity, but something that's very helpful in terms of moving the ball forward on messaging, moving forward. And we are also hopeful to advance the maturity of FHIR messaging in the construct of the next R5 so that it can support these purposes as well. So when you're thinking about automating reporting and automating these processes, another important construct is we really want to use the data that are recorded in the EHR. We really don't want to have the provider enter new data. We don't want to have that manual step to do that. And so we have, for both of these activities, focused very specifically on the US core, or the Common Clinical Data Set, as manifest in FHIR. We were excited to be moving to the US CDI moving forward because of this. We're all over that. We think that the more we can harmonize around the data that are used for these surveillance reports, the better off we'll all be, the less manual entry there will need to be, and the better data we will have. That being said, some of the authorities I mentioned earlier prevent us from getting the entire Common Clinical Data Set. And so it's a subset of that we're using. And there are some data that are not in the Common Clinical Data Set that are critical to public health. So, for example, travel history is one that is, from a clinical standpoint, has not been well structured in the past. We have that in the electronic initial case report because it's so important in terms of public health surveillance. We are also in the referral process, the Bidirectional Services referral process that Arun referenced. We are trying to align with the US core and the base data that are hopefully to be electronically recorded in every EHR. And just to give you a sense for what that is about is this kind of hyper data segmentation that's necessary for those purposes. So clinical care sites actively do not refer to extra clinical organizations right now electronically because a full summary record is too much data to be given to a weight loss program or to be given to a smoking quit line. So, and a big part of this project that Arun alluded to is the concept of hyper-segmenting the data, just the data that are needed for that particular program and for that particular purpose. Of course, this is also why this fits in so well with automating interface development, because getting every EHR to implement we have 6 of these just in our first ballot on the electronic referrals project. So getting them to implement these different hyper-segmented profiles is, in conventional technologies, in CDA technologies, a nightmare. It's not fundamentally doable. Getting them to do them in FHIR, we believe, is much more possible, and we're working on trying to make that as automatic as possible so that these are just part of what EHRs can do without consideration. So I think I talked mostly about this. Some of the specifics of the reporting guidance distribution. There are several different ways that FHIR subscription is helpful in this regard. People can subscribe, get notified using SMS or email. There are REST hooks approaches to getting it. And we've been working with the major EHR vendors to implement this in a way in the HL7 Connect-a-thons that works with their systems and where they can do this electronic conveyance readily. So FHIR offers a great deal of promise in a number of ways for these activities. Even if you're doing push use cases and asynchronous messaging, it still can hugely benefit that activity. And we are actively reaching out to develop strength in numbers, harmonizing with other major initiatives so that we can all be pushing the same direction on FHIR as we move into this new standard suite and hopefully can achieve greater implementation than we've had before. So thank you for your attention. We'd be happy to answer any questions.
I wonder if you could expand on your experience using the subscriber or the push. FHIR, for the most part, is very much a pull protocol.
Right.
What you were able to achieve or how you achieved it.
So FHIR subscription, so part of breaking down what has to happen in the EHR, it's really important to separate out triggering from rules of application. And that sometimes gets conflated and confused. And people say, oh, well, CDS hooks will do that. Well, and we're really, and CDS hooks could have a very important role here, but FHIR subscription has a lot of attractions as a triggering methodology for this as well. And so, one way of thinking about this is triggering, getting it out, then you apply, a rules engine that can apply the more complex logic. We've been very excited about FHIR subscription and its possibilities in that regard. As I said, we've had some headwinds in terms of thinking about reporting data out. And people will say, well, why doesn't the public health agency just reach in and pull those data out? Well, in practice, and I know FHIR is different, but in practice, efforts in the past have precluded that. And it wasn't the EHR vendor that precluded it. It was the healthcare organization. And many healthcare organizations don't even set up selective authorizations for their own staff, much less for a series of extra clinical organizations that should have it. And how would you implement that with, and I'm just throwing out how would you implement that with the fact that it may be reportable to any jurisdiction in the country, because if the patient lives there, it's supposed to be reported there too. And so, we view all of this as very positive for FHIR. We're hugely enthusiastic about what FHIR can do, but we're also trying to do it in a way that that public health isn't having to support apps or extractors that need to go into clinical care. Because public health has frankly had a poor track record of supporting software and efforts of putting software out there. So everything that I've just talked about now, we think can be built into the extended FHIR server environment in clinical care, where we think it's important to eventually have a distributable rules approach for all EHR vendors. That's not there now. Da Vinci is starting to push forward on that. We're excited about that happening because we think we can benefit from it too. But essentially, with that combination of things, we have a tool set in FHIR and the FHIR extended milieu that can provide this kind of reporting function natively. And we're excited about that too.
So the 360X is now what we use FHIR constructs?
I'm sorry, I couldn't hear what you said. Could you just...
360X was an IHE profile. So
Yes.
have they've agreed to use FHIR constructs, or are they going to use FHIR constructs?
So 360X is an IHE activity, and it was mostly around the transactions of making referrals. And they were basically using a summary record as the referral payload. And we've been having a series of meetings with them so that what we put forward in the BSeR specification is completely harmonized with them. And so we're representing in FHIR all the transactions that 360X needs to do. They had not yet moved into the FHIR space. And basically, as far as we're concerned, we don't need two varying approaches in FHIR. We were happy to have them have what they need represented in our approach, and our approach is their approach, is from our perspective in terms of working together. So the simple answer is we are, I think, completely harmonized with them moving forward. We're balloting the BSeR. We're in the dispositioning the ballot now, but we're going to come out of that with completely harmonized specification.
So from a vendor perspective, we're trying to avoid doing the same thing in two different ways. And I'm just saying is with the 360X harmonization, because right now the IHE profile, if it's using the US extension, uses direct messaging. So if this project is sort of moving them to use FHIR-based constructs, then we can just do it one way. I'm asking. Oh, I know you probably.
No, I understand your question, and I don't speak for 360X. We have had discussions about, for example, using a FHIR bundle on top of direct. And I mentioned that earlier because that's a very viable way to go and to implement. But they have been implementing in the IHE standard suite with a CDA summary record. We are hopefully going to have a harmonized specification come out of this so that they could advance their activities in FHIR using these very same specifications. Any other questions, comments? Rotten fruit, vegetables? I'm sorry, between my failing hearing and soft voices.
So I assume since this is regulatory, there's an audit requirement that follow up. Have you looked at that?
I wish there was an audit requirement for case reporting because, we in the architecture, we're certainly implementing audit, but it has not been well enforced. I know of no provider that has gone to jail for not reporting to public health. And so it's a flip answer to your question, but the realities of the current situation are that. And was there another question?
Yeah, on the slide where you have the different descriptions of what data was being sent, I noticed some of the same kinds of data across those different profiles. Are you using the same set of core elements and adding them together in different ways?
So the question was about the BSeR specification and the hypersegmentation, and yes, we have teased that out into three categories of common data. I didn't show it all to you. Okay. Common data, data that are that they all use, data that some of them use, and then data that are specific to a particular one, and they would always use the same data if possible.
I'm sorry. So again, from another implementation question, some of the things that we're experiencing with public health reporting, CDA constructs, even though they conform to the baseline CCDA 2.1, sometimes their value sets do not align, which causes angst for implementation or causes confusion for the person at the point of data collection. Even though the concepts may mean the same, right? But the codes and they're different. So we always sort of have to struggle with that.
It's about differing codes and mappings, and I will wrap up after this, but just suffice it to say that if you can give us specific examples, we're interested in trying to work those through. The other thing we're doing, because of the some EHR vendors said they will do this in FHIR. They won't do it until FHIR is available, is we're developing transforms to convert from CDA to FHIR and back and forth so that those can be used in this approach going forward and enable, take that problem off the table as well. So thank you very much. Appreciate it.